Hello, future nurses and science students. We are the lymphatic system, and we are the ultimate backstage cleanup crew, fluid balance mechanics, and homeland security network of the human body. We don't have a single centralized heart pump to push our fluid around. Instead, we are a massive low pressure network of open ended vessels, organs, and nodes that wind through almost every single tissue of your body, working hand in hand with the red blood cell and the circulatory system. In your advanced clinical nursing courses, you will hear our structures and pathologies described using the root words lymph or lympho, like lymphedema, lymphoma, or lymphadenopathy. If you see those terms, it's all about us. We handle three massive, life-sustaining missions every single day. We reclaim leaked fluids to prevent your patient from swelling up like a balloon. We absorb dietary fats from Miss Small Intestine, and we act as the primary highway and battleground where Luke the lymphocyte hunts down and destroys invading pathogens. The liquid, what is lymph? To understand how we work, you have to look at what happens at the capillary bed where blood drops off nutrients. The leak. As blood pumps through high pressure capillaries, a fraction of the liquid blood plasma gets forced out through the leaky capillary walls into the tissue spaces to feed the cells. This escaped fluid is called interstitial fluid. The reclamation, the veins can only suck back up about 85% of this fluid. That leaves behind about 2 to 3 liters of fluid inside the body tissues every single day. The transition. This is where our open-ended lymphatic capillaries step in. They act like tiny vacuum cleaners, sucking up that leftover fluid along with any escaped proteins, cellular debris, or stray bacteria. The second that interstitial fluid crosses our threshold and enters our vessels, its name officially changes to lymph, anatomy, the routing system, and filters. Once lymph enters our capillaries, it must travel through a highly organized pipeline to be cleaned before it can be safely returned to the bloodstream. 1. Lymphatic vessels and valves. Because we lack a heart to pump lymph, how does it move uphill from your patient's toes back up to their chest? The muscle pump. We rely entirely on the contraction of surrounding skeletal muscles, like when your patient walks, and pressure changes in the chest during breathing to squeeze the fluid along. The one-way valves. Just like veins, our vessels are packed with tiny one-way valves. Once a muscle squeezes lymph forward, the valves snap shut behind it, preventing gravity from dragging the fluid backward. 2. Lymph nodes, the border security checkpoints. As lymph travels up the vessels, it must pass through hundreds of tiny bean-shaped filters called lymph nodes. We place these checkpoints in massive clusters where limbs join the torso, specifically in the groin, inguinal, armpits, axillary, and neck, cervical. The inspection. Inside each lymph node, the lymph must wind through a maze packed to the brim with Max the macrophage and Luke the lymphocyte. The macrophages swallow up any dead cellular garbage or dirt, while the T and B lymphocytes inspect the fluid for foreign antigens. If a virus or bacterium is detected, the lymphocytes instantly trigger cell division to launch a targeted immune strike. 3. The grand terminal access points. Once the lymph is completely filtered, purified, and cleared by the nodes, it empties into 2 massive central pipelines in the chest to be poured directly back into the cardiovascular system. The right lymphatic duct drains lymph only from the upper right quadrant of the body, right arm, right side of the head and chest, emptying it into the right subclavian vein. The thoracic duct, the giant of the system. It drains lymph from the entire rest of the body, both legs, the abdomen, the left arm, and the left side of the head, emptying it into the left subclavian vein. Specialized lymphatic organs. We aren't just a network of pipes. We also include highly specialized organ centers. The spleen, located in the left upper quadrant, LUQ, of the abdomen. Think of the spleen as a giant lymph node designed specifically to filter blood instead of lymph. Its red pulp destroys and recycles old, fragile red blood cells, while its white pulp monitors the blood for systemic infections. The thymus, located in the chest right behind the sternum. As you remember from studying Tommy the T-cell, this is the elite sniper school where young T lymphocytes mature and learn to distinguish self from non-self. Tonsils and Peyer's patches. patches of specialized lymphatic tissue sitting right at the gateways of the throat and the ileum of the small intestine, designed to instantly catch and sample any pathogens that are swallowed or inhaled. Common lymphatic pathologies. When our pipes are blocked or our cells undergo malignant mutations, severe clinical conditions arise. 1. Lymphedema, the fluid traffic jam. If lymphatic vessels are physically damaged, compressed, or surgically removed, lymph fluid can no longer drain away from that limb. The pathophysiology. Because the 2 to 3 liters of daily fluid can't escape, the interstitial fluid backs up rapidly, causing massive, heavy, tight, and disfiguring swelling, edema, in the affected extremity. The classic cause. This is a top-tier nursing blueprint concept. When a breast cancer patient undergoes a mastectomy, the surgeon frequently removes the axillary armpit lymph nodes to check if the cancer has spread. Without those drainage ports, the patient's arm on that side is at a lifelong risk for developing severe lymphedema. 2. Lymphoma, cancer of the nodes, a solid tumor malignancy that arises when lymphocytes mutate and begin dividing uncontrollably inside the lymph nodes or lymphatic organs. Hodgkin's lymphoma, marked by the presence of a highly specific giant mutated multinucleated cell seen under a microscope called a Reed-Sternberg cell, looking like a pair of owl eyes. Non-Hodgkin's lymphoma, a broader, more unpredictable category involving mutated B or T cells without the Reed-Sternberg marker. Critical nursing assessments and implications, mastectomy, limb alert precautions. If your post-operative patient has had lymph nodes removed from their left axilla due to breast cancer, that left arm has a permanently compromised drainage system. The strict nursing rule: you must place a limb alert band on that arm. Never draw blood, start an IV line, or take a blood pressure reading on that affected extremity. The tight squeeze of a blood pressure cuff or the minor trauma of an IV needle can completely overwhelm the fragile microcirculation, triggering irreversible, painful lymphedema. Use the opposite arm or a lower extremity instead. Assessing lymphadenopathy. When performing a head-to-toe assessment, you will frequently palpate the cervical lymph nodes in the neck. You must understand the clinical difference between a normal infection response and a cancer warning sign. Infection, reactive nodes. If the patient has strep throat, the nodes will be swollen, tender/painful, but soft and movable. The pain means they are actively fighting. Malignancy, cancerous nodes. If a tumor is growing, the nodes will typically be painless, rock hard, and fixed/immobile, stuck tightly to the underlying tissue. Finding a hard, fixed, painless node is a major nursing alert that requires immediate diagnostic referral. Splenic rupture, hemorrhage alert. If you are caring for a patient who was in a motor vehicle accident and suffered blunt trauma to their left upper quadrant, LUQ, or a patient with severe infectious mononucleosis which causes massive spleen swelling, they are at an extreme risk for a splenic rupture because the spleen is a highly vascular sponge filtering blood. A tear in its capsule will cause rapid, catastrophic internal bleeding. Monitor them intensely for signs of hypovolemic shock, a sudden crash in blood pressure, skyrocketing tachycardia, and sharp pain referred to the left shoulder, Kear's sign. Keep them strictly NPO,